Hi, thank you for giving me the opportunity to speak with you today. My name is Elizabeth Stewart. I'm a clinical nurse too here within the organization. And in staff meetings the last several months, we've been really talking about improving our pressure ulcer rates, which will lead to better infection rates, which would lead to smaller hospital stays, which is better for insurance costs and um, the spiral down the road. So, after hearing that, I decided to really kind of look into the evidence based research to see what was out there for mobility plans, what we could do to keep patients out of the bed to prevent skin breakdown. And I used the American Cancer Society, I used cancer.org. They have a lot of different research on mobility and different things that we could do for patients that are receiving chemotherapy. And then there is a ton of evidence based research, and I have some of the articles here with me today that we can look over and kind of see where I pulled some of my information from that really supports developing a strong mobility plan within the unit. I also sat down with our house therapists, both occupational and physical therapy, just to kind of see what their input is and what us as nurses at the bedside could do to really support them when they're not working with the patients, since they're really only seeing patients for maybe 30 minutes every other day. Just there's so many that need care. So, what can we as nurses do in between their therapy visits with the actual therapist that we can help safely move them and keep them from getting pressure ulcers? So, sitting down with the therapist, some of our big ideas were there's no way to do a universal plan for patients that are bed bound all the way to mobile walking miles around the unit every day. There's no way to make a universal plan that's beneficial for everyone. So we've come up with a plan, and I have it right here. We kind of developed based on if they're bedbound, if they can walk, and what we expect the nurses and the care partners to do for them every day. The biggest thing, regardless of mobility, is that we want patients to be able to sit up for meals. So 3 times a day, they're at least sitting on the side of the bed, they're sitting up in the bed, they're in the chair, we're using lifts to get them there. Whatever that we can do to really help the patients feel like they're at home, because most patients aren't eating in bed at home, and we don't eat in bed at home. So that's something that we really want to try to do for the patients. We also talked about doing a lot of resistance, like ankle pumps for the patients that are stuck in bed, developing how often patients can walk around the unit, 3 times a day, walk 5 laps around the unit, and a lot of just like passive motion. So this plan, based on what we came up with the therapist, is going to be very minimal cost. Basically, it's everything that just the patients and the nurses are able to do on their own and assist each other. I think in addition to the treadmill and the standalone bikes that we have on the unit, being able to get some small hand weights, maybe 2, 3, 5 pound weights, just for patients that are able to do a little more and are used to going to the gym, we can incorporate that into their mobility plan. And maybe just getting some resistance bands just to kind of help with the patients that are bedbound to kind of add a little more resistance instead of just pumping their ankles, but that's very minimal cost. I think in the long run with this plan, we're putting very little into it besides education, and we'll be able to get a lot out for both the patients and for our infection, pressure ulcer rates, and our length of stay for patients that are requiring longer hospital stays due to lack of mobility and maybe requiring a inpatient rehab facility stay after their chemotherapy to get their strength back. So the biggest thing is just education for this plan. We just need to educate our care partners, our staff. We need to get therapists that come to our unit on board. So we'd have several different in-services with the therapist would be hosting and myself to just make sure everyone's on the same page with the mobility plan. This page spells out exactly what we want each level of mobility for each patient to be able to do. So we have this as a resource for everyone. Everyone's using following the same thing based on what they're able to do. We have a standard one per level of mobility, and report the nurses and the care partners can pass along which one that they're doing so they're getting the same experience every day. And then as they're getting stronger, we can even move them from being the bed-bound ones maybe sitting on the side of the bed or getting up with assistance, and as they're getting stronger, we can adjust based on what their needs are. In addition to just in-service, to go over it, we'd have super users, a care partner and a nurse from each shift, for day shift, for night shift, for the in-between shifts, as what we would consider a super user. That would just be the point person if anyone has questions or needs assistance or trying to figure out which category the patient falls under, to have as resources no matter the time of day. So if the therapists aren't there, if I'm not there, we'd still have someone that's available to that was super trained to kind of help with the mobility plan. In order to track how well this mobility plan is being used, after several months of it being implemented into daily practice, like to sit down with the nurses and the care partners and get feedback. What's working really, really well? What's not working so well? Are you having a hard time adding this into your patient care that's already established? What can we do to provide better resources? And then our unit secretaries are documenting where patients are being discharged to every day anyway on a chart. So in addition to that chart, we're going to add a new column for how many days the patient stayed, to see if we're decreasing how many days they're staying by keeping them mobile, and where they're going. So are we able to send them home with maybe just home health coming to see them and physical therapy at their house instead of going to a facility? And then overall, if we're able to decrease the length of stay and how many people are going to an inpatient facility, then we are able to decrease insurance costs, the hospital costs, and ultimately we're lowering pressure ulcers, which is then decreasing infection rates. So by working on this all together, we're helping patients with so many different things, with insurance costs, our hospital costs, and really just hopefully overall having better patient satisfaction rates, which we will also see how well that's working with our patient satisfaction surveys and talking about mobility, and if they really felt like they were able to move more through their chemotherapy treatment, being able to follow a plan like this and having staff members encouraging them to move.